Obviously, health insurance is insurance related to your health. All of us know in this room know it's no surprise that health insurance costs are huge. If you have to pay for it yourself, it's probably going to bankrupt all of us very quickly. So it's amazing when you get a prescription filled, and if it's out of your pocket, you pay like $200 for something that, you know, if it's insured, then you pay $5 for it. So without debating why it is that way, the point is that it is what it is. And so this insurance, health insurance, deals with managing your health-related costs. So here's some examples of what it could cost you. So here's a female 25-year-old non-smoker, and you can see monthly base rate of, what is it, $106. So these are the limits. And so that's $106. I mean, this is just to get you a idea of comparative costs for demographic, you know, in terms of different demographics. Here's a female 25 smoker, and the rate goes up to $122.39 from $106.49 for a similar policy. Here's a okay. So here it is, the non-graphic version for a typical county, this particular county. And the 25-year-old male, that's 180 versus 190. So roughly about similar, very similar. But this is a non-smoker. Females in 30 years, so it'll go up from, you'll save, so it's going to be $500, almost $600 a year. $600 a year when you are about, what, 50 years old? Now, smoking is really considered to be very serious and does increase your rates very significantly. So, and what we have seen, interestingly, interesting fact here is that if you declare yourself to be a drug user, your rates do not change that much. But if you label yourself as a smoker, then your rates go up a lot. So, so that's a kind of a bit of a mystery why that is the case. But clearly smoking is a big... Now the question is what happens, and I get asked this question a lot every semester, is, or at least once every semester, is what happens if you don't tell them that you're a smoker and get the non-smoking rate? The problem with that is that if they catch you, and it's really very high, if you're a smoker, it's very hard to hide that. Anytime you go in for a checkup, it's very easy. A simple blood test or any kind of thing will reveal nicotine or whatever. I mean, there's many ways to detect that. So, and if you're caught lying, then the insurance policy can be canceled very easily. The insurance company doesn't have to pay anything to you. So, so lying on your policy is not a good idea. And so, here's some types of insurance. I'm going to go through some of these definitional aspects quickly because you can read them yourself. But the bottom line, the way the healthcare system works for the most part is that you have groups of physicians, whether it's a hospital network or a physician's network themselves, that are then affiliated to a hospital. It's the same idea. It's a fee-for-service kind of plan. So you go visit your doctor, whoever, and there is this thing called in-network and out-of-network. You may have heard this term. In-network simply means that the particular doctor belongs to this network of physicians that is recognized by your insurance company as within the network. So in other words, it's cheaper to go in-network, but if you, the physician that you're comfortable with happens to be, doesn't belong to that particular network, then you're in trouble. Your choices are then to find another physician who's within the network, or pay a ton of extra money to go to the same physician. But the idea is the same. Whether the physicians, a bunch of physicians come together to form a group, and then they have an affiliation with the hospital, or the hospital themselves hires different physicians and networks directly with the patients. So in our particular county, we have both. So you may have heard of the Unity Healthcare Group. So Unity Healthcare Group is nothing but a bunch of physicians, actually surgeons, who came together about a decade ago and formed a group. And they have an affiliation with St. Elizabeth Healthcare Network, the St. Franciscan Alliance. And so that's how they operate. And then there is the IU Network, Health Network is a direct hospital group, part of the Indiana University Health Network. So they operate here as well. So you have both of these systems operating side by side, and people, depending on what kind of problems they have, choose one or the other. So it's fairly simple. So that way, so you see your doctor. It's a fee-for-service kind of plan. That's basically how it all plays out now. So I'm going to health maintenance organizations, preferred provider organizations. You can read through them, but the bottom line is really this: that there's very subtle differences, but for the most part, the way the system works is exactly as I said. Yes.
Turn up the volume.
Can we increase the volume? Yeah.
We can plug it in.
Oh, that would help, wouldn't it? All right. Better? Thank you. You should have raised your hand sooner. Nobody's listening anyway other than you. You're probably the only one listening. So it doesn't matter what I say. So it's all right. Well, so what should you choose? So you have all these, and really there's, on a practical basis, there's really not, there's not a whole lot of choice in the sense that you find a family practice doctor. So when you move to a town, whether with a job or as a student, if you're a student, you're part of the university system. So the university healthcare is basically where you go for your issues. So we have that here. When you graduate, you move and you find a new town and you go, you make inquiries, find a family physician, a healthcare practice person, and he or she becomes your primary go-to physician. And then if you need specialized attention, then that particular doctor refers you to a specialist. So that's basically how it works. So this thing about whether or not a lot of times you don't have any choices. You just pretty much follow what is available in the neighborhood you move in. So, but it's always good to be, wherever you are, good to be within network. So whatever that means, find out whether the company or whatever you're working for, what is the network. So the company will usually have an insurance company that it deals with for all of the payoffs, insurance-related payoffs. So that insurance company defines the network of physicians that it works with as within network. And it's always good to stay within that because of reasonable healthcare costs, or at least relatively speaking. So who provides health insurance? So there are different organizations. So you have private insurers like Blue Cross Blue Shield, a number of, our staff insurance provider this year is Blue Cross Blue Shield. Government agencies provide help. That's the Medicare program that was passed into law in 1965. And then of course there's the Medicare and then Medicaid for low-income folks. And then of course there's the workman's compensation kind of idea. So if you work in a factory and you get hurt at work, then there's ways to compensate there. And so all these are included. You have all this different coverage. Again, when you what kind of coverage to choose? Obviously, you want the best coverage, best possible. But the problem is the best possible may be too expensive. And so it becomes a question of an optimization along the lines of, okay, what is the best my money can buy, or whatever I'm comfortable spending? So, and usually, so I'll use the example of how this university does it for its faculty and staff. And so you have different levels of plans. and some plans are cheaper, and other plans are more expensive. So what they encourage people to do is to choose the cheaper plans, and the university kicks in some money to encourage people to choose those cheaper plans by putting extra money in a flexible spending account, health-related account, which the more expensive plans won't have. So the university has various ways to try and incentivize its employees into choosing the cheaper plans. So if you feel, for example, that you're young and you're healthy, you're in good shape, you're not likely to go and visit a doctor a whole lot in the coming year, then you save yourself some money, you go for the cheaper plan, which also saves the university money. Or else, if you feel that you're not well, or you and your family members will need to use the the healthcare facilities a lot in the coming year, then you choose the more expensive plan, which has more inclusive coverage, but it's more expensive upfront. So it's really that kind of optimization that you do in terms of balancing your needs. So you don't pick a plan out of vacuum, right? You have to sort of look at yourself and your family and say, okay, what are the potential needs that we may face in the coming year? Now, of course, there'll be things that'll be like a curveball that you won't anticipate, but those are not things you can plan on. I mean, accidents happen, and those are not, you can't plan on that. But what you can do is to look at yourself and your family members and see, make a realistic assessment of what the needs are likely to be, and then make a determination as to whether to pay extra and get a more inclusive coverage, or pay less, save money, and get the less inclusive coverage. And that's basically what you're faced with all the time anyway. Okay, so in terms of money-saving options, these are the two things that where you bear the risk: deductibles and co-insurance. So deductible comes out of the first dollar loss, and co-insurance comes out of the last dollar of your loss, or your claims, in this case, health insurance claims. So if you have a $5,000 bill, and you have a $500 deductible policy, and an 80-20 after $4,000, then basically what will happen is the $500 out of the $5,000 comes out first. That's your expense. And then the insurance company will pay up to $4,000, and then anything over $4,000, it'll be an 80-20 co-insurance. So they'll pay 80% of the rest, and 20% will be yours. Why does the insurance company structure these contracts like that? We've talked about it. They want to make you, the customer, or all of us, financially responsible for the health bills in order to promote responsible behavior. Because if the insurance company pays for everything, then we have this moral hazard problem that we've talked about. The idea being that we're just simply going to act in ways that would increase our bill, and that's going to be expensive for the insurance company, that we're going to try to go overboard because we don't have to pay for it. So by making us financially responsible through deductibles and co-insurance, it's one way of insurance companies of trying to keep costs manageable. And the fact that we as insurance contract holders do not go overboard and we maintain good health and all that stuff. So that's sort of the incentivizing device that insurance companies use. As we said, insurance companies, you cannot make money out of insurance. So if you have multiple policies, then they'll all come together and pay exactly the amount of your bill, no more. So some of these things you need to be careful, just be aware of is the cancellation policies. What are the cancellation policies? What are the COBRA policies? So if you change jobs, what happens? And so you need to be aware, because one of the major problems or dangers of insurance coverage are gaps. So if you have a policy that lapses and there is no coverage for a while, and then that's an absolute no-no, because a lot of times when you don't have continuity, you can get in trouble because something that happens to you after that can be blamed on the period that you didn't have any insurance coverage, and the insurance company can deny you payment Just so, as long as you have continuity in coverage, you're safe, you're protected. But it's usually a very bad idea to drop coverage in between. So COBRA helps the continuity process in between jobs and coverage. Pre-existing condition is a dangerous thing for us because once insurance company labels something pre-existing, that means they're not going to cover anything related to that condition. Anything even remotely related to that condition gets lumped into that umbrella, and then it's a problem. So that's a danger that's always there. In terms of long-term care insurance, again, these are the following questions you ask, and if the answer is yes, then the answer should be you might need long-term care insurance, else you don't. Usually it's for seniors. Moving on. Again, long-term care, the questions are in terms of benefit requirements, how long will it go on, what is the waiting period, because usually there's a cooling period. Coverage, even with disability that we'll talk about soon, the payoffs don't start right away. There is a period, like a 6 month or 3 months before of a cooling period when you don't get paid, and then the payments start. So it's good to know how long that's going to be. Is this policy guaranteed renewable? That's important because if your health is going to decline in the meantime and you have to take a fresh medical exam to qualify, then you may either be priced out or you may be put in a high-risk bracket. That means your healthcare costs become much more expensive. Disability insurance is one of the unsung insurance policies. The statistics show that you are more likely, all of us in this room are more likely to be disabled than outright die of something, right? So, but yet disability insurance is something we sort of blow by and we don't really consider very seriously. Most of us might have life insurance policies, but nothing to do with disability insurance. And so what is important with disability insurance is, and especially if you're working for a factory or for on the production line and things, this becomes an important aspect to think about. Definition of disability, that's kind of counterintuitive. You wouldn't really think about the fact that we all know what disabled means, yet different policies have different definitions of what is disability according to that policy. Until you qualify, you are not disabled in the eyes of the policy, and i.e. you're not going to be paid. So the definition of disability is very important. So the most desirable definition from a policyholder standpoint is this own occupation aspect. So if something happens to you that precludes you from indulging in your own occupation, whatever you're trained to do, then you're disabled. That's the best definition from a policyholder standpoint, and that's the most liberal definition. But that usually accompanies policies that are more expensive to have. The cheaper policies will have a much more stringent definition of disability than this one. So obviously what is desirable for us is not so for the insurance company. So it's a kind of a zero-sum game. Again, same kind of questions. How do you estimate needs, estimate your monthly living expenses? This is where budgeting helps. This is where, you know, the stuff that you've been doing, maintaining a record of expenses and stuff. So budgeting, if you've maintained a budget, if you do a budget, then you have a pretty good idea of what your monthly expenses are, and then it's easier to come up with a measure of monthly living expenses that you can then use towards any insurance needs. All right, let's, what are some of the questions? I think we're supposed to do that, right?
Yeah.
Yeah. So I'll hold off on the affordable care discussion until a later date because we'll discuss it in class.
Especially about pre-existing conditions.
I don't understand how insurance companies cannot pay for, pre-existing conditions. Does this include prescriptions? Prescriptions are for medication, right? So if the medication relates to a pre-existing condition, then yes, then medication may not be covered. But usually I don't think the medication, I've not heard of medications coming under that kind of scrutiny. It's usually surgical procedures, expensive surgical procedures that are related to pre-existing conditions that are usually denied if they fall under that rubric. So it's more to do with surgical procedures and other expensive medical treatments, not so much the medication and stuff that you're taking. I don't think that's under the purview. At least I've not heard of that. But it's when you talk about pre-existing condition, we're talking about expensive surgical procedures. Those are where the insurance companies balk at paying up because that's big ticket stuff that they have to pay out. What is the upside for health insurance companies? Because everyone upside, they make a ton of money. So I don't know what is the upside for health insurance companies because everyone claims insurance at some time or even periodically. What is the upside? Upside in terms of profit? I mean, they're making a lot of money. Insurance companies, as I said, insurance companies and oil companies are the two most profitable segments of the economy in the U.S. Yes, everyone does claim from time to time in their lives. That's true. But for most of us, I think it's safe to say that we will probably end up paying more into the system than we'll get out. The point is not to make money, right? This is for peace of mind. The reason we get insurance is purely defensive. It's a defensive strategy, and it's not a question of whether you're getting out as much as you put in. The fact that you have peace of mind and you're covered in case something goes on is the value for why you have insurance. It's not like investments where you're buying stocks because you want to make money. That's not the goal here. Do rates for insurance go up if, say, one gets diagnosed with some type of cancer? No. Just because you get diagnosed with cancer, I mean, you have insurance precisely for that reason. It's not going to go up for that reason. But what will happen, is that as there is more and more stuff, let's say you've used the word cancer, so I will expound on that a little bit because my wife is a cancer physician here in town. So what will happen and what she has to do is after a certain point when the costs go up, insurance companies will start to deny certain procedures. And then it's up to the physician to call the insurance company and argue as to why that is necessary. And so you have to keep doing that. So a conscientious physician will keep doing that. You have to fight for the clients to get, for your patients to get paid. Because unless a physician can make the case for why a particular procedure is needed, it can get denied. And insurance companies usually will deny first because they know that the physician will call in and then so insurance companies have a lot of physicians that are under their payroll. And so a particular physician has to call and talk to another physician who's the expert under that insurance company in order to make sure that this is a procedure that's approved, that follows the guidelines and all that stuff. And then once that gets approved, it goes on. And this whole process becomes more and more tenuous, difficult as the procedure goes on. So insurance company, because as the insurance companies pay more and more, they get stricter and stricter as to what they allow. So it becomes a sort of a cat and mouse game at that point. So that's how it works. So it's not like, in that sense, health insurance is a lot different than, say, auto insurance, where you will be dropped. I mean, well, you do some things over and over again, or you rack up certain accidents and stuff, then there's a good chance that you can be dropped. But in health insurance, you won't be dropped per se, but it gets more and more difficult to get certain procedures approved as they start paying more and more. Pre-existing condition, I don't think it's broken bones. We're talking about serious illnesses like heart-related problems, liver disease. I mean, we're talking not broken bones or anything. Pre-existing condition is not, those are not, it's related to some serious health issues like related to vital organs and stuff like that. That's what this covers primarily. Can insurance rates fluctuate when you get sick or after multiple injuries? I don't believe so. You are based on, well, they do look at, and this is where continuity comes in. I mean, if you get a policy at a time when you have all these issues, yes, then you'll be put in a high risk bracket and you'll have to deal with a lot of the pre-existing conditions and things like that. But if you have continuity in your health policy, then it is what it is, and you'll bill, and if the insurance company feels it's appropriate, they'll pay. Otherwise, you will have your doctor talk to their doctor and try to come to some understanding. So that's how the process works. Now I'm going to not touch that one.
Okay.
I think it is unfair that health insurance companies readjust premiums based on claims. Well, overall, that is true, but the reason they do that is because of increased perception of risk. So again, insurance companies are in it to make money, right? I mean, that's the whole, like it or not, that's how the process works. And so if it's like saying, okay, so in the investments world, how does it work? When your perceived risk goes up, as an entity, then you have to pay more to borrow money. So think about bonds, right? When a company sells bonds, if your rating goes down, that means you're considered to be a higher risk. The interest that you have to pay out to borrow money increases, doesn't it? How fair is that? Is that fair? Think about it. Well, our U.S. government, the AAA rating no longer exists, right? We are AA plus now, right? So that means when bonds are issued, new bonds are issued by the U.S. government, federal bonds, they now have to carry a higher interest rate, relatively speaking, because now we're considered to be slightly higher risk than we were before, which is almost no risk. Now that's changed, and that increases your borrowing cost because you're now viewed to be more risky, right? So the insurance company is operating on the same procedure, the same idea. If somehow you give through whatever, you give the impression that you're now a higher risk, then your rates go up, or other exclusion criteria comes in and stuff, and they try to manage the cost, their cost. So that's how it works. I mean, it works in the investment world, it works, I mean, insurance is nothing but they are a profit-making entity. It's not a non-profit. So that's how it works. But okie dokie, moving on. So we all know this, right? Healthcare costs have spiraled out. There's a lot of debate going on as to how to come to grips with it. What does one do? There's stuff that's out there that's debated. Who knows what the landscape will look like in the next 10, 15, 20 years. It's definitely going to be different. We don't know how or what. So it's really, we are in a state of flux with the healthcare system. Everybody agrees. We all, I think, agree that it's too expensive. It's getting out of hand. If you speak to the doctors, they will tell you that they're getting less and less in reimbursement. So, and I think, I'm not sure I mentioned this to you. So the way the healthcare reimbursement works is that, so let's say you use a procedure, you go to the hospital, you spend whatever time you needed to and get the right care. Then let's say the hospital has a bill for your stay and medical care and all that, whatever that is. I'll pick a number, $10,000, let's say. So the $10,000 gets submitted to the insurance company. So you have insurance, the bill's $10,000. the hospital sends that bill over to your insurance carrier. And guess what happens? There is a reimbursement rate, which means that usually insurance companies will reimburse hospitals or doctors or whatever at about anywhere from 30 to 40%. So a $10,000 bill gets reimbursed at $3,000 to $4,000. So it's not like the insurance companies are paying the full thing. So they are seriously discounting the bills that come to them, right? So they are, and so that's what doctors are now getting squeezed out, because doctors will tell you that they hardly get reimbursed a whole lot because the insurance companies are squeezing out whatever the bill is. So there is enough finger pointing going on in every direction, and it's not clear how this will all pay out. A lot of times, what a lot of physicians are doing, physician groups and hospitals, is that they will not see Medicare patients. A lot of hospitals in town will say that we won't see Medicare patients because the reimbursements for Medicare patients is hardly anything. It's not. Physicians will say that it's not. They don't get anything, hardly anything out of Medicare patients. So a lot of Medicare patients are being left high and dry. So there's a lot of problems in the system right now, and it's not clear how it'll all play out in the next decade. Again, some statistics that I think Michael came up with. This is Michael's contribution here. And Michael has a case study that he wants to tell you about.
All right. So I don't think I necessarily need the microphone.
Please.
All right, I'll take the microphone. So before I started college, this was the period of time I gave myself between high school and college. I traveled across the country installing operating room equipment. So the big surgical lights, the anesthesia booms, the AV equipment, fiber optic cameras. It was really cool and really expensive. So the company that I was working for, the guy started it and founded it and made himself a millionaire just taking things that hospitals were throwing away, these pieces of equipment, and he would clean them up and he would resell them because they were precious. They had precious metals. It was high-grade steel, aluminum, what have you. So he was able to build up a company. I think he's got well over 2 or 3 dozen employees now, just based on how much things costed in hospitals that they were just throwing away. So that's one of the critiques of the healthcare system. Things get so expensive, and hospitals, to pay for these new products, have to charge more, and it just gets wrapped up in a cycle. So one of the things, we might discuss it with the Obamacare plan, is that the subsidies have to be paid for by something, somewhere, so it means more taxation on the drug companies and the medical supply companies. So these parts will begin to cost more. So healthcare definitely is not free. So that's my case study.
Okay. All right. Where do we moving on? Okay. So these are some stats. So you have 70% of healthcare dollars are being spent on, diabetes, obesity, heart disease. And that's why there's a huge drive now in terms of preventive healthcare. So rather than waiting for the condition to happen, if you pay for things, insurance companies have seen the benefit of paying for incentivizing people to lead a healthier life so that they don't fall ill or as seriously as. So Purdue University has its own plan for its employees to walk and take better care of themselves, eat well, so on and so forth. So that there's more emphasis now on preventive care rather than waiting for the disease to happen. So that's where one of the focus is on in terms of healthcare in terms of containing healthcare costs, is to encourage healthier living styles, lifestyles, and so on. Eating healthy, working out. So here's some more stats. about half of bankruptcy filings in the U.S. are due to medical expenses. What about universal health care? Well, that's the whole idea. Boston, Massachusetts was one of the first states that started it. Seems to be working. No system is perfect, but it seems to be moving along. There are other countries that are under that. U.S. is one of the only countries that in the developed world that has issues related to health care or all the debate that's going on. So this is the Massachusetts plan, and so one argues that the Affordable Care Act that the current president passed was really modeled along the Massachusetts plan, the state of Massachusetts. So here's some facts about, at least as far as we know now. So one of the major thrusts of the Affordable Care Act, and again, as I said, that it has its critics, it has good and bad, and nothing is perfect, so there's always criticism of things. But the idea is that what the whole idea, the intuition for this whole plan, and which is the same thing with the Massachusetts plan, was that there is a ton of people, millions of people. I think some estimates about 50 million people in this country out of a population of 300 million plus. So about 1/6 have no insurance. Excuse me. Thanks. So about 15% of the population doesn't have insurance. And the problem with that is that these people still use the system. It's not like 15% of the people are saying, you know what, we are just going to stay away from the healthcare industry. If something happens to us, we are just going to tighten our belts and ride it out. That's not the case. So what's happening is that the insured people are also using the healthcare facilities, and so that puts pressure on the entire system. Because when those people you cannot get money out of, they are not able to reimburse hospitals and physicians for their services, that becomes a problem. And if it's that large a number, so how do you bring those people into the fold in some reasonable way? That is the big debate. So everybody understands the basic premise, right? And I think everybody agrees that this is a problem. What people don't agree about is how we fix this problem. And, all sides have valid points. So it's that issue that's under debate, is how do you deal with the uninsured? The point is that these uninsured will use the system, they are using the system, but you cannot refuse them care, and so what do you do? How do you deal with that? That's the basic problem, a challenge that we have. And affordable care is so when people have insurance, they're in some sense partially subsidizing. Well, we are subsidizing now people who do not have insurance. So that's the whole idea, and that's why it's becoming expensive for everybody. And so the idea is, how do you form this coalition of drug manufacturers, healthcare providers, and other businesses, as well as the government, to create subsidies so that the system becomes a little bit more fair. That's the whole idea. Now, you can quibble, you can complain, and that's fair. Okay, I think everybody has some fair points to raise, but that's the ultimate problem, or the challenge that we face, is that how do you, in a reasonable framework, deal with the uninsured so that the entire system does not implode, which is where we are right now. What other questions do we have here? Michael, are they hiring? Okay, I don't know. Hey, it's your case. Yeah, how do insurance companies handle pregnancies? Do women? I don't know. My wife, we had a baby last year. It was, you submit a claim and it gets paid, and same way as any other issue. I don't know that there's anything else that. Is Obamacare going to? I'm not going to get into any kind of. As I've told you at the beginning of the lecture, that I do not take position. My job as a teacher is to present all sides as I see it, and so I'm not going to answer. On average, how much do insurance rates go up for things we discussed? Different insurance companies have different internal models, so it's hard to predict. Yes, hospice is covered in end of life care. So hospice is typically when it's past medical care. So once conventional medicine is done, there's nothing else to do. That's where hospice steps in for comfort care. So yes, that is very much under insurance, and a specialist has to sign off on it, but definitely. In line of what my wife does, that's a big part of what the treatment plan, or keep a patient comfortable with medication and so on.